This is EHJ today at the annual Congress of the European Society of Cardiology in Rome, Italy, and I'm Tom Luescher, Editor-in-Chief of the European Heart Journal, and I'm talking here with Robin Jäger, structural interventionalist from Basel, Switzerland, and with Bernard Chevalier from Paris. Welcome, gentlemen.
Thank you.
So, Basket Savage is a clinical trial. What's the question that you wanted to address?
Thank you. The trial we performed was a trial in saphenous vein graft interventions. We had a couple of years ago the question whether drug-eluting stents are an issue for safety of the patients because there were the issue of late stent thrombosis. And the problem is that saphenous vein grafts have a really distinct pathophysiology that is totally different to native vessels. And the fear was that there is an increased rate of late stent thrombosis and therefore clinical events. We have two trials, randomized trials in the field with a long-term follow-up, and both showed an increased mortality rate for drug-eluting stents compared to bare metal stents in these saphenous vein grafts. And therefore we aimed to perform a clinical trial in saphenous vein grafts using drug-eluting stents and bare metal stents. The sample size was 240 patients, and unfortunately we were not able to recruit all patients, but we had a decent number of patients, 72% of the projected sample size.
So the power calculation was 240?
Yes. But we based this power calculation on quite high event rates, so 30% in bare metal and 15% in drug-eluting stents, which was afterwards not the case.
So what were the patient characteristics?
We had a really high-risk group of patients. They were more than 70 years old, mostly male, and the cardiovascular risk factors were really high. Lots of renal failure, strokes, prior MI, and of course all were operated on before because they were vein grafts.
Of course it takes some time until they develop the disease, the vein graft disease, so they tend to be older. And so the design of the trial was? It
was a prospective randomized trial. We randomized the patients one-to-one to drug-eluting stents and bare metal stents, and we strongly recommended the use of filter wires and glycoprotein 2B3A inhibitors. And at the end of the trial we had 66% with filter wires and 74% with glycoprotein 2B3A.
And the stents that you were using?
We used the Taxus stent as the drug-eluting stent, and the backbone of the Taxus stent, the Liberté stent, as a bare metal stent. The choice of the stent was due to the fact that at the time of the trial design in 2007, this was the only stent that allowed the treatment of these large saphenous vein grafts. And
what was the reason that it was difficult to recruit such patients?
That's a good question. I think what we see in clinical practice is that the rate of saphenous vein graft interventions goes down, mostly probably due to the fact that we intervene more in patients and operate less in patients. And clinically, we mostly, with the new materials we have, the nice stents and all these wires and stuff, CTO interventions, we have the possibility to intervene in the native vessels, which is probably better for the patients than saphenous vein graft interventions.
Very good. And so what were the results?
Okay, the primary endpoint was MACE at 12 months.
What do you call MACE then?
Was cardiac death, was non-fatal MI, myocardial infarction, and target vessel revascularization.
Stroke was not included?
No, it was not included. No. And we did a long-term follow-up after 2 years, 3 years, 5 years, and we had a median follow-up time of about 3 years that we have data from. Mm-hmm. The results we saw are a really high event rate in bare metal stents at about 18% after 1 year and 30% after 3 years, and a really low drug-eluting really low MACE rate in drug-eluting stents of 2% at 1 year. That is very similar to native vessels, and of 12% after 3 years. And all this was highly significant. MACE was mainly high regarding MIs and TVRs, in these patients. There was no issue with stent thrombosis and was not at all an issue with cardiac death on the long run.
And you used filter devices, so acute no reflow occurred rarely?
It occurred about in 2 to 3% of patients only. I think this is a very remarkable result because we used the glycoprotein 2B3A inhibitors for a really good indication. All this friable material going down, making thrombosis, I think you can avoid that with a pre-medication with this glycoprotein 2B3A inhibitors.
And the low stent thrombosis rate was due to the fact that these are large vessels mainly, or?
And that we intervened with large stents in these large vessels, yes.
What was the average size of the diameter of the stents?
In our trial, 3.7 millimeters.
So really big, huh?
Yeah.
I see. Good, that's a very interesting result. So, Bernard, what do you think about the trial?
Well, I think it's an important trial because, as you said, there was clearly a strong recommendation to use a DES in saphenous vein graft PCI, but mainly based on relatively short-term, at least 1 year data, mainly based on ESAR cabbage trial. And there was a question mark about the long-term benefit due to the safety issue, due to the fact that we know that atheroma in saphenous vein graft is rapidly progressing. And your trial is important because it's clearly emphasizing the benefit at 3 years of using a systematic DS strategy. Of course, we can say that it was a relatively old style DS because it was the first generation DS, but as you said, it was the only one which was available in large size at that time. And again, I think in previous data we have from registry, there is no clear benefit of second generation DS versus first generation DS in this specific indication. So I think it's also very important to keep that in mind when you look at the data.
So you think that the very new ones would even be better, like the everolimus eluting stents?
It's possible, but so far the data we have are not going in this direction, at least in terms of safety, meaning death on myocardial infarction. There is no clear benefit in registry. We have a large registry from veterans in US, 2,500 patients approximately, and no significant benefits of using second generation DS versus first generation DS in this specific indication. This is probably related to the fact that, as you said, it's a very large device, and usually 4 or 4.5 millimeters.
We were discussing this before. You as an experienced interventionalist, when do you go for the bypass and when do you go for the native vessels? That's an important decision when you have a patient with a angina or ischemia after a bypass surgery.
Yeah, we try effectively to promote native vessel PCI because we know that the long-term outcome is much better because we have this issue of atheroma progression in saphenous vein graft. So the systematic approach is to try to reopen the native vessels, to try to address this long-lasting chronic total occlusion. And this is the explanation why it's so low now to use saphenous vein graft PCI. I checked in my practice in the last 12 months, it was less than 1%.
Less than 1%? Yeah, sure. And if you do intervene in the vein grafts, you would also use the protection devices, the filter devices?
We use almost systematic protection devices if the anatomy is fitting with this practice. What we don't use systematically is 2B3 inhibitors, which is a little bit old-fashioned approach for PCI in a saphenous vein graft, because we know that it's more embolization is more related to atheroma debris because it's very friable material than real thrombus.
Yeah, you see this also when you place you open the vessel and then you place the stent and then you have the no reflow because all this dirty stuff that's hanging in the vessels is embolizing, and I agree with you. So the take-home message would be use drug-eluting stents, use filter devices, And of course, the 2B3As is discussable depending on whether it's an acute presentation or a more chronic presentation. I mean, we have also sometimes the acute presentation of bypass occlusion, then I would certainly also use the 2B3As. And so it's important for practice, and although not so common at these days, it is still a challenging clinical problem, and we're thankful for the results that you present today at the Congress. Thank you very much, gentlemen.